Welcome to everyone in part 2 video the Pheochromocytoma. Here we see the various feature of the Pheochromocytoma that signifies the malignant nature of it, and also we see the clinical features and what various laboratory diagnosis we do to identify or to diagnose Pheochromocytoma. So first we begin with the features that suggest malignancy in Pheochromocytoma. First feature is vascular invasion. The tumor cell invade the surrounding blood vessel, which suggests the aggressive nature of the pheochromocytoma. Second feature is capsular invasion, where the tumor cell invade the adrenal capsule, and later on that will metastasize to other extra adrenal tissues, and this also signifies the malignant nature of the pheochromocytoma. Next is necrosis. Areas of the tumor necrosis where cell appears as shadowy outlines with pycnotic nuclei, and this also shows the aggressive nature of the tumor. And the fourth feature is cellular atypia, where there we can see increased mitotic figures, atypical mitosis, and profound nuclear pleomorphism. Pleomorphism means the variation in the size, shape, and this also show the malignant nature of the pheochromocytoma. And next we can appreciate the growth pattern. There will be the loss of the typical Zell-Wallin architecture with largeness or diffused growth. We had seen in the previous video, that is part 1 video, where we had seen the benign condition Zell-Wallin architecture are appreciated in the microscopic feature of the pheochromocytoma that was surrounded by the sustentacular cells, and so these types of microscopic feature of the pheochromocytoma will be lost once it begin to go towards the malignancy. Next feature is a definitive sign of malignancy, where we see there is the metastasis to distant sites, most commonly that occur through the um, lympho, uh, lymphatic system. So next we see the clinical features, the cardinal symptoms. The triad. First we go through the triads that we appreciate in the pheochromocytoma. First is headache, and this could be severe, and that result from the increased blood pressure that is caused by the tumor's catecholamine release. That means the tumor of the adrenal medulla, especially of the chromophil cells, and that results in the excessive secretion of the catecholamine, and we know that that has adrenergic effect, and thus it result in increased blood pressure, which eventually lead to the headache. Next, we appreciate sweating, that is diaphoresis, and that is also caused by the increased body temperature and the sweat production from the catecholamines due to the activity of the catecholamines on the sweat glands and the hypothalamus that will stimulate those glands. That means sweat glands, and it will also stimulate the hypothalamus and eventually lead to the sweating. And palpitations, and this is the feature of rapid heartbeat, and we know that these catecholamines act on the beta cells, beta receptor present on the myocardial cell, and there that will have uh, positive chronotropic, ionotropic, and dromotropic action. So this will increase the heart rate and contractility, and this eventually lead to the sensation of the rapid or pounding heart, which is called as palpitation. And other common sign and symptoms that we can see in the person who are having the tumor of the adrenal medulla, that means chromaffin cells, and we see the hypertension, that the dominant features in the 90% of the patient, and less than half of the patient with the hypertension, they show the paroxysmal episodes that gets precipitated by the emotional stress, exercise, and changes in the posture and the palpitation in the region of the tumors. We had seen in the first part of this pheochromocytoma that Extraadrenal sites are there which are involved in the pheochromocytoma. There is involvement of the carotid body, organ of the Joker candle, and various other sympathetic and parasympathetic nervous system, and that refer as paraganglioma. So, wherever the tumor is present, extra adrenal or adrenal tumor, whenever there we palpate, then that will exaggerate the paroxysmal episode of the hypertension, and this occur in less than half of the patient who are having hypertension being affected by the tumor of the adrenal medulla. And next we say if there is urinary bladder paragangliomas, then that will precipitate this paroxysmal episode of the hypertension once that person feel micturition. That means micturition will precipitate this paroxysmal episodes of the hypertension if that patient is having urinary bladder paragangliomas, and about half of the cases show the sustained hypertension, that is that remain throughout the life. And other features associated with the hypertension could be tremor, that is a physical trembling or shaking of the hands, anxiety and nervousness or sense of apprehension, unease, fear or irritability. Such things are also associated with hypertension. And pale skin, that is a temporary paleness of the skin. And next could be pain in the chest or abdomen, nausea and vomiting. And we know that in the pheochromocytoma catecholamine is excessively released, and these catecholamines act on our beta receptor of the myocardial cells. So if any person is suffering from congestive heart failure or pulmonary edema or myocardial infarction or ventricular fibrillation, so in such patient, if there is a tumor of the chromatin cells, then that will precipitate these types of the condition of those patients. So this can also be seen. And lab diagnosis, before going to the lab diagnosis, we see the uh, metabolism of the catecholamines. Here we can see that epinephrine and norepinephrine, with the action of this catechol O-methyl transferase, leads to the O-methylation of the epinephrine and norepinephrine to metanephrine and um normetanephrine, normetanephrine and metanephrine, with the help of this catechol O methyl transferase. And once this get converted to the metanephrine or normetanephrine, then with the action of the monoamine oxidase, that get converted to the vinyl mandelic acid. And if initially this epinephrine is acted upon by monoamine oxidase, then that will form the dihydroxymandelic acid, and this will also happen with the norepinephrine. So at that condition, this catechol O methyl transferase act on the second stage, and that will convert this dihydroxymandelic acid to vinyl mandelic acid. So in this pheochromocytoma, more amount of the catecholamines, this epinephrine and norepinephrine will be secreted and released. So these metabolites like metanephrine and normetanephrine and vinyl mandelic acid, such metabolites of the catecholamines will be seen excessively in the urine. That means there will be the increased urinary excretion of the free catecholamines as well. Along with that, there might be uh, metabolites like a vinyl mandelic acid and metanephrine. Such things can be seen there. Thank you. This much now.